Welcome. Let's start with urinary system anatomy so every label in later sections makes sense. The urinary system consists of the kidneys, ureters, bladder, and urethra. Here are the kidneys, right and left. Each kidney drains through a ureter. Urine is stored in the bladder. And finally, urine exits via the urethra. Flow, kidneys to ureters into the bladder and out through the urethra. Renal arteries bring blood in. Renal veins carry filtered blood out. Keep these landmarks in mind. Cortex, medulla, renal, pelvis, ureteral orifices, and the external urethral meatus. The nephron is the functional unit of the kidney responsible for filtration. Each kidney contains about 1 million nephrons. This is the glomerulus, surrounded by Bowman's capsule. Then the proximal tubule handles bulk reabsorption. Next, the loop of Henle concentrates and dilutes filtrate. The distal tubule fine-tunes electrolytes. Collecting ducts finalize water balance under ADH. Blood enters via the afferent arteriole and exits efferent. Filtration pushes water and small solutes into Bowman's space. Reabsorption and secretion modulates sodium, potassium, bicarbonate, urea, and water before urine exits. GFR measures how effectively the kidneys filter blood. Higher GFR equals stronger filtration capacity. Compare healthy kidneys to those with chronic disease. Filtration declines over time. Normal GFR 90 to 120. Moderate decline 30 to 59. Severe decline less than 30. Clinically, we estimate GFR using serum creatinine, age, sex, and race-neutral equations. Trends matter. A falling eGFR signals disease progression. Hemodynamics affect GFR. Afferent dilation raises it. Efferent dilation lowers filtration pressure. Education point: hydrate appropriately unless restricted and avoid nephrotoxic drugs. Patients with kidney failure often develop hyperkalemia. Normally, kidneys excrete excess potassium through distal nephron secretion. In renal failure, reduced flow and aldosterone response impair K+ secretion. Cardiac changes progress from peak T waves to widened QRS and dangerous dysrhythmias. Look for weakness, paresthesias, and, if severe, flaccid paralysis. Potassium, normal 3.5 to 5.0. Elevated, greater than 5.0 milliequivalents per liter. Obtain a 12-lead ECG in any moderate to severe elevation. Stabilize myocardium with IV calcium for ECG changes. Shift potassium intracellular with insulin plus dextrose, beta agonist, or bicarbonate as indicated. Remove potassium with diuretics, binders, or dialysis in renal failure. Continuous cardiac monitoring, frequent K+ checks, review meds, and strict renal diet education. When blood pressure falls, the kidneys release renin. Step 1, blood pressure decreases. Step 2, kidney releases renin. Step 3, angiotensin I forms from angiotensinogen. Step 4, ACE converts angiotensin I to angiotensin II. Step 5, potent vasoconstriction increases systemic vascular resistance. Step 6, aldosterone release from the adrenal cortex. Step 7, sodium and water retention expand intravascular volume. Step 8, blood pressure increases toward homeostasis. Clinically, ACE inhibitors and ARBs interrupt this cascade to protect kidneys and control BP. Monitor creatinine and potassium when starting or titrating ACE-IE ARBs. Normal female anatomy features a shorter urethra, increasing infection risk. Bacteria enter the urethra and ascend toward the bladder. Colonization leads to bladder mucosal inflammation. Expect dysuria, frequency, urgency, suprapubic pain, and sometimes hematuria. Older adults may show delirium or nonspecific decline. Urinalysis: positive leukocyte, esterase, and nitrites, bacteriuria, and pyuria. Urine culture confirms organism and guides therapy. Routine imaging is not required for uncomplicated cases. Consider ultrasound if recurrent, febrile, or obstructive features appear. Treat uncomplicated cystitis with targeted oral antibiotics per local resistance patterns. Hydration and short-course urinary analgesics may help. Avoid in renal insufficiency. Teach preventive hygiene and timely voiding. Afebrile dysuria without flank pain suggests lower UTI, not pyelonephritis. Case, 22-year-old with dysuria and positive nitrites. Start empiric therapy and counsel prevention. An untreated UTI may progress into pyelonephritis. Infection spreads from the bladder, ascending the ureters. Inflammation involves the renal pelvis and parenchyma. Expect fever, chills, CVA tenderness, and flank pain. Systemic symptoms are common. Urinalysis may show WBC casts. Obtain urine and blood cultures if severe. Imaging is reserved for obstruction, stones, or treatment failure. Use empiric IV antibiotics for severe cases, then tailor and step down orally. Provide fluids, antipyretics, and analgesia. Monitor for sepsis, track urine output, and ensure follow-up cultures if indicated. Pearl, dysuria with fever and CVA tenderness indicates upper tract involvement. Case, 68-year-old with diabetes and fever, admit for IV therapy and imaging for obstruction. Here's the normal prostate encircling the proximal urethra. The enlarged prostate compresses the urethra. Chronic obstruction can cause bladder changes and retention. Symptoms include hesitancy, weak stream, intermittency, dribbling, and nocturia. Watch for bladder distension and urinary retention. PSA may be considered. Interpret with shared decision-making. DRE often reveals a smooth, enlarged gland. Check post-void residual if retention is suspected. Start with behavior changes and review obstructive medications. Alpha blockers relax prostatic smooth muscle for rapid symptom relief. 5 alpha reductase inhibitors reduce gland size over months. Procedures like TURP are considered for refractory symptoms or complications. Monitor retention and teach medication effects and hypotension safety. BPH, smooth enlargement versus nodular, hard lesions raising cancer concern. Transurethral resection of the prostate removes obstructing prostate tissue. A resectoscope is passed through the urethra to access tissue. Obstructing tissue is resected, restoring urine flow. Post-procedure, urine flow improves significantly. A Foley catheter is placed to drain urine and irrigate the bladder. Continuous bladder irrigation prevents clot formation and obstruction. Monitor output color, maintain patency, and avoid traction unless ordered. Teach expected effects like transient hematuria and retrograde ejaculation and when to seek care. CBI prevents clot formation following TURP surgery. Use a 3-way catheter, 1 port for inflow, 1 for outflow, and 1 for the balloon. Irrigation fluid enters the bladder and helps flush out clots. Expect color to progress from dark red to pink to clear as bleeding resolves. Titrate flow to maintain light pink output, preventing obstruction. Accurately calculate urine output by subtracting irrigant infused. If spasms or low output occur, assess for clots and gently irrigate per protocol. Do not discontinue traction or CBI without an order. Report bright red bleeding or persistent clots.